Welcome to this lecture on quality control and artifacts in PET imaging. These are the objectives for this lecture. The first step in ensuring image quality is acceptance testing. This is performed whenever a new camera is installed or purchased, and it should be done before use. This is performed by a medical physicist with experience in PET system evaluation, and it must adhere to the performance measurements of positron emission tomographs. And there is a need to verify that all the corrections are correct, as they will be applied to all of the images. PET-QC will vary per system. It also depends on whether it's standalone PET, PET-MR, or PET-CT system, and the manufacturer's recommendations. But the summary of the importance of PET-QC can be viewed by answering the following questions. For the daily QC, we want to answer, should we scan today? You just want to make sure that nothing has changed since the last time the scanner was used and that it's okay for use that day. For weekly QC, we want to know, how well is the scanner operating? Have there been any significant changes through the week or over the weekend that would change its ability to operate efficiently or effectively? For quarterly QC, you want to know, has the scanner changed over time? You're looking at the overall stability of the system. And annually, you want to know, is the scanner still performing at its best? QC for PET is more a matter of updating and refining calibration settings than performing test images. This is very different from traditional gamma cameras. We want to recalibrate and kind of tweak the system rather than testing it to see if they're necessarily if the test images are going to pass. So QC for PET, like I said, is a matter of updating and refining calibration settings for the most part. When we're looking at the characterization or operation of the system, it's fundamental to the camera's operation. We want to look at the energy, the positioning logic, the PM tube gains. If there is a system that has PM tubes, it may be a newer digital system. In that case, you're still looking at energy resolutions and high voltage supplies and things like that. It's just a little different. And then we also want to look at the coincidence timing window. Now, when we're performing QC for corrections, we want to correct for inherent variations that occur. So this would be your normalization and your blank scan, and then the absolute activity, also known as the well counter calibration. So the summary of the QC, the energy window calibration, where we're looking at singles, coincidence timing. You want to make sure the coincidence timing window is acceptable for use, performance of a blank scan, normalization, absolute activity with the well counter, and then if it is a PET-CT system, you also have to do the CT QC for hybrid scanners. Now for the energy window calibrations, also known as singles, the PET detectors just naturally have poor energy resolution. This increases scatter events that are detected. It's got a wide window, typically of about 34%. So even though it's centered on 511 keV, it's going to accept anything between 425 and 600 keV, which means that especially down closer to the 425, 450 keV, you're going to end up accepting a lot of scatter. The energy window calibration does set the energy window for the pulse height analyzer, and then it's performed using a germanium 68 source that's placed in the bore of the gantry. Data is acquired and processed to adjust the detector module gain settings. The energy window calibration is performed during preventative maintenance, after repair, or just before a normalization study. This is usually performed by a field service engineer. So it's not typically something that a technologist is a part of or performs on their own. Now, coincidence timing. This is a calibration that's performed to compensate for differences in detector module hardware, and this is going to adjust for the timing difference in the event detection circuitry. And you want to make sure that you are able to accept counts within a certain timing window and that those are synced up between the different detector modules. This usually uses germanium-68 as a source of that as well. The gain settings are performed weekly or daily. This adjusts the amplifier gains from the PM tubes, and this is adjusted to compensate for temperature changes and fluctuations in sensitivity. For this one, we use a phantom with a known radioactivity, and then errors will impact the sensitivity and quantification of the data. Now for the routine quality control, every day a blank scan is performed. This is sometimes also known as an air scan, but this is a short time acquisition of the rods or a cylindrical phantom, and it verifies the function of the tomographic instrument of the PET scanner, and really it's looking for bad detector blocks. Remember, with our daily QC, we want to know, is it okay to scan today? Is the camera going to work for us today? And so one of the main things that we're looking for there is to make sure there's no detector blocks that are bad and make sure that the instrument's okay to use for the day. So that's the purpose of the daily blank scan. And if you see a lot of drifts in the values on the blank scan, then it means that your scanner requires a new normalization study. So the blank scan has to be performed before a scanner use for the day to correct for drifts of dead time and sensitivity. It acts as a daily measure of uniformity and for attenuation correction. Inaccuracies in the blank scan, though, will result in artifacts on the patient images. This is viewed via a reconstructed sinogram. Each line or point represents a specific location between two coincidence detectors. If you see broad diagonal lines on a blank scan, it means there's a bad PM tube or a bad detector block. If it's a bad PM tube, it tends to be a thinner line, and if it's a detector block, it tends to be a thicker line. Remember, with the scanner design, you have several PM tubes coupled together in one detector block. So it makes sense that if it's just a bad PM tube, it would be a thin line, whereas a detector block is going to involve several PM tubes, so it's going to be a much thicker line that you will see. And any abnormality there indicates that that there's an issue in the system that needs to be evaluated. This is an example of a detector block failure. This is failure of a PM tube, a detector block, or a bucket, or other electrical component that creates an obvious defect on the sinogram. So even though we say malfunctioning PM tube or detector block, keep in mind that those are electronic components. And if the electrical supply to them, high voltage supply, any of that circuitry in there is disrupted or malfunctioning, then it won't work either. So it'll look very similar. But a single malfunctioning PM tube produces alternating light and dark stripes on the sinogram. And this will kind of sort of look like edge packing. The next QC is a normalization calibration. I like to describe this very similar to a uniformity correction on a regular gamma camera. It sets the uniform sensitivity to all detector modules across all line of responses. And it's performed after major service or preventative maintenance, and at the very minimum is performed quarterly. It should be done in 2D and 3D modes. The temperature, humidity, and unstable power may impact the scanner and require a new normalization. And this is performed using a low count rate source. A normalization scan is a long-time acquisition of the rods or germanium-68 cylindrical source. This takes several hours to complete. A lot of time technologists will set it at the end of the day and it will perform overnight. Every crystal is compared to average of all detector modules, and it generates the normalization correction factors, calibration sensitivity factor for each detector. It has to be a high quality scan, and that's one of the reasons that the acquisition takes hours. It's gathering a lot of counts. It can be performed monthly based on some recommendations from the manufacturer. Mostly it's performed quarterly and less routinely as a correction. It corrects for scatter and may be performed with low, and it must correct for scatter and it must be performed with low dead time and no pulse pileup. And it should be compared to previous and new sinograms and then subtract the difference. Now, cross calibration, also known as absolute activity or the well counter calibration, this correlates the count rate in the 3D image matrix with the activity concentration of the cylinder. The well counter calibration is performed weekly or monthly until stability is established. It may also be done with a dose calibrator. It's used to convert pixel values into a measure of absolute activity per voxel. It should be performed for 2D and 3D imaging, and it's performed only after other calibrations have been completed, and it's done quarterly or after service. And this is also typically performed by field service engineer. This image is just showing you how the different calibrations are combined to create a more uniform image. So in this one, you have the normalization created better uniformity, and you have the cylinder, which that is applied to create a more uniform source. This image is showing you how the normalization is applied to an image so that it creates a more uniform image. In the first one with no normalization, this is a cylinder phantom, and you see that you have a lot more denser counts placed in the center. And then once that normalization is applied, it does create a more uniform image. And you can see in the bottom diagrams as well. So with the cross calibration, a normal patient dose is added to a cylindrical phantom. 1 milliliter is removed for measurement on the well counter or dose calibrator. The phantom is imaged, reconstructed, and processed into correction factors. Correction factors equal the percent of injected dose per volume or gram of tissue. And the per voxel count rate is compared to the count rate in the sample. That's why this is better to use a well counter for that, but you can use a dose calibrator also. The activity concentrations should be within 5% if the normalization scan was accurate. And that's one of the reasons too that it needs performed after the normalization study. So uniformity verifies uniformity of the cylindrical phantom. This is a cylindrical solid phantom of either germanium-68 or an F18 fluid-filled phantom. If you're using the F18 fluid-filled phantom, it is very important to make sure that that is uniform throughout the phantom. It is then reconstructed with a ramp filter, and individual slices are inspected using regions of interest to determine positive and negative differences. You're essentially just measuring the uniformity across the face of the phantom. Some corrections that are done, random, scatter, dead time, and attenuation. The random, scatter, and dead time are measured using the cylindrical phantom. All corrections are applied before reconstruction. and it's applied to each projection, each single sinogram data. And this is built into the software, so it's not something that a technologist performs. It's just a correction that you need to know is there. After application, then reconstruction, the voxel should accurately represent the amount of radioactivity in the voxel. And this is verified by the absolute quantification of PET. The cylinder phantom is scanned with uniform radioactivity, and the calibration factors are then applied to make sure that it is accurate. Corrections for randoms are a really important correction in PET imaging. Recall that random coincidences occur when two photons that belong to different events reach the detector opposite each other within the coincidence timing window. So they're from two different annihilation events in two different locations, but they just happen to both reach the detectors opposite of each other within the timing window. So these are a problem in PET because they end up getting assigned a line of response and can be detected. They will add to the background and they will reduce the image contrast, but they don't actually add any benefit. So it's very difficult to remove for randoms, but it's important correction. So there are two methods. One is a delayed window and singles. So with the delayed window, the coincidence timing window is shifted to only allow delayed events. The amount of random stays the same and is detected, but no trues are detected. This allows for calculation of a random rate. And then that random rate is then subtracted from the amount of events that it's occurring. So correction is made then to subtract the random rate from the recorded events. Singles are estimates of randoms based on an equation. It calculates the rate of singles and then applies that to the equation to determine the amount of random coincidences. This applies the correction for randoms based on a calculation. Scatter corrections are also very difficult with PET imaging and will degrade the image quality. Scatter results in a hazy background in the reconstructed images and reduced contrast. It can also lead to quantitative calculation errors. Recall that with scatter, with PET imaging, the scatter comes from the 511 keV photons that are scattered within the patient. They'll arrive to the camera and kind of be detected and create different lines of response when they aren't actually where they came from. So the fraction of scatter is very high with PET, especially in 3D PET. It's about 60 to 70%. So only one annihilation needs to scatter to create a scatter event. If both of them hit the detector within that coincidence timing window, then it ends up being a misplaced line of response because it'll still get detectors that are kind of opposite of each other that can count, but they're scattered photons, and so the line of response won't be accurate. When you have dense crystals with the PET scanner, you have a lower light output. This leads to lower energy resolution and it requires a wider window, which leads to more scattered counts that are counted. The pulse height analyzer window is also widened with PET imaging. If you recall, it's about 425 to 600, somewhere around in there. So that's a really wide window. It's about 35%. And that can further account for Compton scattering that occurs as photons interact with the crystals. The scatter is related to attenuation. Of course, the higher the attenuation, the more scatter counts you'll see. The CT map is really good to use for determining scatter fractions. After correcting for randoms, the only events falling outside of a scanned object are scatter. So the scatter profile is created and deleted from the image prior to the reconstruction. This is by no means a perfect process. It's very difficult to see what's scatter and what's not. Some things may get applied to scatter that aren't really. Some scatter gets missed. So it's really not perfect, especially when the scatter is complex, and that will occur in the brain because the photons have to pass through the thick skull bone, um, with heart-lung interfaces, and then with patients who have a really high BMI. All that scatter can degrade the image quality. Dead time correction is another very important correction. Dead time, all the PET scanners are susceptible to dead time because they have really high counting rates. Part of that is because you can use a higher dose to the patient with PET, but the patient still gets a lower overall radiation dose than a lot of general imaging procedures. So you also need to give a higher dose because of the really short half-life. And then also because of the short half-life and it's decaying very quickly, you have more counts coming off of the patient than you do with something with a longer half-life. So you have really high counting rates with PET, and that leads to dead time and pulse pileup. Pulse pileup will lead to misplaced counts, and of course, dead time will lead to lost counts. So the method varies based on the scanner model and the manufacturer. Some use a mathematic filter, some apply global correction, or to the individual detectors. I also want to point out with the dead time with PET scanners, especially if you're doing cardiac PET, for example, you want to pay really close attention to the count rate that you're getting and the ability of the camera to process those. Sometimes you may need to reduce the dose to the patient in order to avoid dead time. Some scanners are just a lot more sensitive than others, so they're a little more susceptible to dead time. And this is an example of attenuation correction. On the top, you see the attenuation corrected images. On the bottom, you see the non-attenuation corrected images. It is important to look at both, especially if you see something that looks a little abnormal. If you're doing PET CT and you see an artifact and you're not sure if it's artifact or if it's misregistration between the CT and the PET, you can look at that overlap to see on the fused images if it's misaligned. And you can also look at the non-attenuated corrected images to see if that artifact is still there. If it's not there in the non-attenuated correction images, but it is in the attenuated correction, then you know that that's a fusion error. So that created that artifact. So especially if you have a difficult case, it's important to look at both. The noise equivalent count rate is also important. This accounts for additional statistical noise that's introduced by random and scatter corrections. The equivalent count rate that gives rise to the same statistical noise level as the observed counting rate after the random and scatter have been corrected for. This is very useful in comparing the performance of different scanners. Some more quality control tests that are a little less frequently performed, that energy window calibration and detector identification maps, coincidence timing calibration, accuracy of dead time corrections, accuracy of scatter and attenuation correction, and measurement of scatter fraction, spatial resolution, and the noise equivalent count rate. So all of these tests are performed infrequently, which means it's either monthly, quarterly, semi-annually, or even annually. And it is recommended to have a medical physicist perform these tests. Accuracy of calibrations and corrections are particularly important because they will be applied to all imaging studies and because the accuracy of the quantitative results depends on them. Especially if you're doing SUV calculations, myocardial blood flow, it's really important that the scanner have all of the calibrations and corrections where they need to be so that errors are not introduced into the images. Keep in mind the manufacturer recommendations and the protocols for these QC will change. They're very different based on manufacturer recommendations and frequency. So just a general overview. Daily, you will perform a PM tube check, blank scan, uniform cylinder, point source study. And then weekly, uniformity, well counter calibration, coincidence timing check, and energy window calibration. Some of those may be done monthly if your scanner is stable, hasn't had any issues, and more frequently if you're in a high volume place. Quarterly preventative maintenance, normalization, and cross calibration, and then annually that NEMA testing may need repeated, including spatial resolution, sensitivity, intrinsic factor, scatter and count rate, updated normalization factors, and the well counter calibration. There are a lot of things that can cause a scanner to fail. Malfunctions with the detector or detector block, high voltage drifting, energy drift, gain drift, cable breakage, power supply drift or failure, temperature drift or cooling system failure, coincidence timing malfunction, transmission source or robotics malfunction, septal positioning and misalignment, or imaging table failure. It is very common, especially with a little bit older PET-CT cameras who have the robotic arm for the QC source. That is very common for those robotic arms to malfunction. So if you're having trouble with the QC source coming out or a transmission source, if you have a standalone PET, just keep in mind that that is a very common error. Another thing is the power supply that to just consider. And I want to point out that a lot of people have UPSs on their scanners. Of course, that's kind of standard now to have a UPS for your scanner. But I want to point out that there's so much power and high voltage supply going to a PET, especially PET CT scanner, that UPS really won't prevent power fluctuations. It's going to just do temporarily for a second, keep it going, but it's not a generator. You won't be able to finish scanning a patient. This is an illustration of how the sinogram can be used to identify detector problems. In A, you see a normal sinogram. Notice the crosshatch pattern. That reflects the normal variation in efficiency between the detector elements of the system. In B, you have a really thin, dark diagonal line that indicates a failing detector element within the system where no counts are generated in that line. With C, you have a broader, dark diagonal line that indicates an entire detector module is failing. And D is an example when a detector module is generating random noise. E is an example of when the receiver or multiplexing board of the signals in a group of the detector modules is failing. So you might see this if, so keep in mind you have several PM tubes in one detector block, but then you may have a bucket or group of detector blocks that all have the same power supply and circuitry coming from them as those start to group together. So that will cause a much larger example, a much larger black space. It's just what you see in E. With F, that's an example of problems in the coincidence processing board. In this case, the signals from two groups of opposite detector modules are lost. And then with G, that's problems with the histogramming memory where random numbers are added to the valid coincidences in the sinogram. Now we're going to shift gears a little bit and talk about some of the PET QC phantoms. This is a cylindrical germanium-68 phantom. That's the one that's used for normalization and uniformity testing and may also be used for scatter. Pictured here is a phantom used for acceptance testing. This has routine quality evaluation of the PET CT system. It allows for evaluation of new image fusion software and attenuation correction algorithms. It has aluminum tubes for registration, and the outer 2 inches has a microcylinder for comparing the attenuation region to non-attenuation region. And then it has a 6-inch ring for contrast solution, and this is often also used for research. This is an example of an alignment phantom. It's used for verification of image alignment and distortion in PET-CT systems. And it consists of a cylinder that can be filled with a variety of fluids, and then several non-parallel rods that have varying diameters. As you can see on the end here, each one of them is a different size, and at certain angles in relation to the phantom's axes, they run the entire length of the cylinder. Images are produced with different modalities to allow quick and simple identification of misalignment and fused studies. This is a NEMA phantom. It allows for simulation of whole body imaging using PET and camera-based coincidence imaging techniques, and it's used for evaluation of reconstructed image quality in whole body PET and camera-based coincidence systems. It allows for the determination of coincidence count rate characteristics for brain and cardiac imaging, and evaluation of the relationship between true coincidence count rate and radioactivity, and determination of the address errors caused by address pileup, and evaluation of count loss correction schemes. And then what you see here is the ACR phantom. There's also one with a modified faceplate for JZAC Deluxe, and that is used for image quality testing for accreditation. For the American College of Radiology accreditation, iCannal does not require this. And if you can see here, there are various rods that are different diameters, and then you have the spheres of different sizes. This is fluid filled, and then that is scanned usually with, for PET, it has F18 in it, and there needs to be resolution of so many, usually second to the smallest or second to the largest rods. And then also for the spheres, you need to at least see like the middle one. So like the JZAC Phantom, the flangless Phantom comes with cold rod insert and solid spheres. The lid is a little bit different. It has a number of individually filled cylindrical chambers of various sizes, and it can be filled with air, water, or higher concentrations of activity. The flangless ESSER PET Phantom is used for system performance evaluation, acceptance testing, and routine quality assurance. And this is a variation of the JZAC Phantom that's designed for clinical quality assurance of PET systems. Now we're going to shift gears again a little bit and talk about some image artifacts that are common with PET. Artifacts in PET can be due to the electronic malfunctions, especially those caused by PM tube or detector block failures, ray artifacts, which are used due to filtered back projection and standalone PET, and motion and misregistration artifacts. This is usually due to paint chip motion, but there are times when you may have some misregistration between PET and CT images. This is an example of a ray artifact. Image A is a coronal slice with reconstruction using filtered back projection. And in B, it's the exact same slice, same patient, but reconstructed with iterative reconstruction. Filtered back projection is typically seen with standalone PET, and filtered back projection is typically seen with PET-CT. But figure A shows the coronal maximum intensity projection image of an oncologic FDG study that was reconstructed using filtered back projection. And then in image B, you see the same image using iterative reconstruction. Note that the ray artifacts on the filtered back projection image are not present on the iterative reconstruction. And you'll see that these are the ray artifacts here. It almost looks like little stripes through the image. This is an example of a truncation artifact that is seen with PET-CT, and this is created when the body goes outside of the field of view for CT, and as that attenuation correction from the CT is applied and is fused, it will create a hot spot on the images. This is an example of a motion artifact seen in the inferior aspect of the brain. Note the double exposure at the base of the brain where the arrow is pointing. The brain tissue appears as it should, but then there's an area of relatively decreased FDG uptake below it. Then intense uptake is seen again. And that's because the base of the brain moved a little bit, so you see the base of the brain showing up again. Patient shifted between the two superior bed positions so that the brain tissue was registered in the second bed position, and then below the base of the brain acquired in the most superior bed position. You can also see where the second arrow is pointing to, there's a little shift in their pelvis as well. That's another example of a motion artifact. And you can almost see the outline of the bed position there as that one bed position is shifted. Some bed overlap artifacts can occur when normalization correction is not adequate for the count loss in the axial front to back tomograph. And then hotspot artifacts will be seen in an area of high activity. Dead time and attenuation correction artifacts may cause the tissue around the hotspot to be cold. This is an example of bed position overlap. You see that it creates these lines through it. You also see that there's a little bit of the base of the brain is missing there as it didn't line up very well. This is an example of a hotspot artifact. When the positron emitting source is used as a transmission source, any annihilation photons detected in the transmission scan will be assigned to the attenuation map. This figure shows non-attenuation corrected and attenuation corrected coronal slices in a patient with retention of the radiopharmaceutical dose at the injection site. So I want to point out down here is where you're seeing that artifact occur. You have the hot spot from the injection, but then immediately next to it, it appears cold. Now the image on the left is showing a normalization error. Recall that earlier I told you it's very similar. The normalization is very similar to the high count uniformity correction map that's done for gamma cameras. And so it should appear like the image here on the right, but the image on the left is showing a normalization error that's resulting in these concentric rings that are showing up. And this is an interesting image. This is not an error that you will see very often, and it can be difficult to detect, but it almost looks like there are routine hot spots. It almost looks like the patient's wearing hot buttons or something, even though this is on their back. This is increased activity due to a bias in the normalization, and it's showing up in every bed position. If you look at the top, you even see one up there. And this is an example of respiratory diaphragm artifact. This is a motion artifact that's seen because of the movement of the lungs and the diaphragm as the patient is breathing. And in this image, you see patients scanned with their arms down and how that can create these hot and cold spot errors. And then this one is a failure to apply sensitivity corrections. You end up seeing a cold line at every bed position. There is a little bit of overlap in every bed position. And this one, it doesn't apply the corrections for that. So it's creating an error. This is an example of incorrect attenuation correction. You see that it is misplacing counts and it's creating hot and cold spots on the images. You see in A, it's leaving a complete blank spot in part of the brain or part of the head. In this one, you see where it's kind of tracing the body outline. It's intensifying the dark counts or the counts of highest intensity. So it ends up creating this outline of this patient's body. And this is the effect of scatter correction applied to a hot bladder. It's creating one of these hot spot artifacts where it's creating a cold spot immediately around it. And now we're going to look at some images of common artifacts that are seen on PET-CT imaging. This is an older picture. It's pretty grainy, but this I wanted to use to show you the comparison of a detected crystal in a PET scanner versus a detector block. Remember, the crystal is a much smaller component. A single PM tube is much smaller, whereas the detector block is several PM tubes grouped together. That typically has to do with a power failure or high voltage supply issue where the entire block becomes defective. This one is an example of a coincidence failure. These images are both blank scans. There are two different sinograms. On the left, you have a coincidence accepted. That one is a passing result. And then on the right, you see a coincidence failure. Hopefully this one is recognizable. I'm going to give you a minute to think about what this one might be. The red arrows are pointing to it. So that one is a motion artifact that's caused by respiratory motion. And you can see because the right around the diaphragm, it's actually shifted. And there's a blank spot there between where the top of the liver is and the spleen. This one has an arrow pointing to it. I'm going to give you a minute to think about what that one might be. And if you guessed bad crystal, you're correct. Notice it's a thinner line, so it's not an entire detector block, but this is an example of a bad crystal. And I'll give you a minute to look at this one. This one's not as obvious, but it does have an arrow pointing to the artifact. This one is another respiration error. It's much more subtle right here where the arrow is pointing to it, but this one is a respiration artifact. I'll give you a minute to think about what this one might be. And here's where the artifact is, down by the patient's pelvis. And this one is an arms down or motion artifact. The patient actually had their arms down and then moved them to rest on their pelvis. Looks like they have free-floating hands. And this one is darkened up quite a bit to accentuate that artifact. I'm going to give you a minute to find it. And so if you guessed that this was an arms down artifact, you're correct. This artifact right here, where you have a cold artifact or cold defect, that is caused by the patient's arms being scanned down. You also have a slight truncation artifact here on the side of the arms, and that's also caused by the arms being down. But where you have this bright activity that is misplaced along the edges, that is a truncation artifact. And then this cold spot right here is the arms down artifact. And this is the last one. I'll give you a minute to test your knowledge. You have the CT image on the left, the PET image in the middle, and the fused image on the right. And if you guessed truncation artifact, you are correct. This is an example of truncation, and you can even see down here along the edges, right here, it's kind of misplaced, some counts, but that is a truncation artifact. And that concludes this lecture on image quality in QC and PET-CT imaging. Thank you for watching.